Good afternoon, everyone. From Pediatrics Unit 1 and the Division of Pediatric Nephrology, we shall be presenting a child with CKD who was also found to be HIV positive, and he was on dialysis for a very long period and then finally got a renal transplant done. So we will take you through the journey of this child, the challenges that we faced in conducting the renal replacement therapy, etc. The case will be presented by Dr. Tanvi and will be discussed by Dr. Rahul, and both Tanvi and Rahul are doing DM pediatric nephrology. So Tanvi, please.
A very good afternoon, everybody. I'm Dr. Tanvi, RDM, Pediatric Nephrology. The topic for today's CCR is the challenges of kidney replacement therapy in an HIV positive recipient. I'll be presenting the case of Master S, who is a 17-year-old boy born on 5th March 2005 and resident of Haryana. He has been symptomatic since infancy with straining during maturation and weak stream. At 9 months of age, he developed a urinary tract infection and pneumonia, following which he was worked up, and at 1 year of age, he was found to have posterior urethral valve with bilateral hydronephrosis and grade 5 vesicular urethral reflux. He has 2 other siblings, one is an elder sister and a younger brother. At 1 year of age, he underwent valve ablation. This was all evaluated outside. And at 2 years of age, he had a bilateral ureteric reimplantation. In 2009, he presented to us for the first time. At that time, his creatinine was 1.4 milligram per deciliters, which corresponds to an estimated GFR of 29.5 ml per minute per meter square. Then he was lost to follow-up for the next 3 years and again presented to us in 2012 when his creatinine had increased from 1.4 to 2.9 and eGFR of 16. In 2014, his creatinine increased to 5 with an estimated GFR of 9.2, and he was initiated on dialysis. Initially, 5 sessions of hemodialysis were given. This was followed by initiation of continuous ambulatory peritoneal dialysis from December 2014. These dialysis sessions were initiated outside AIIMS. He also received 1 unit of blood transfusion. On evaluation of transplant, he was found to have HIV positive. In Jan 2015, which was 2 months post the initiation of dialysis. His parents were tested negative, and the possible source of infection was kept as either the hemodialysis session, the blood transfusion, or the surgical intervention he underwent for the valve excision. He had multiple difficulties while he was on dialysis. Hemodialysis was obviously a challenge as none of the center had accepted him to dialyze him in view of the HIV positive status. Hence, he was continued on CAPD for 8.5 years, starting from December 2014, with manual cycles, as the use of cycler was not feasible. Disinfection was particularly challenging, as the content of the drain bag had to be disinfected with bleach, following which only it could be discarded. The cost of therapy was around 3.6 lakhs per annum, and he had 4 episodes of peritonitis while he was on CAPD. For the transplant workup, his blood group was A negative, and the blood group of father was also A negative, and that of mother was AB negative. So initially, father was worked up for transplant. However, transplant was initially deferred in view of his HIV positive status. In 2020, again, the transplant workup was restarted. At that time, father was found to have nephrolithiasis, and he was rejected as a donor. Grandparents were also we also tried to work up the grandparents, however, they were not willing for the transplant. Then in 2022, we considered mother as a donor for the ABO incompatible transplant. However, at that time, there was a lot of resistance from the paternal side. The paternal side had almost given up on the child in view of his HIV positive status. Hence, mother also denied to be a donor. Finally, in April 2022, he was listed for the cadaveric transplant. His CD4 counts remained good throughout, and he had almost non-detectable viral load throughout. Initially, he was not started on ART as according to the guidelines during that time, if the CD4 counts are good, there was no indication of ART. Then in 2018, in August, ART was initiated as per the guidelines. As at that time, irrespective of the CD4 count, we have to initiate ART. Hence, he was initiated on efavirenz, abacavir, and lamivudine. After initiating the ART, he developed pancytopenia, followed by 2 episodes of Stevens-Johnson syndrome. Hence, the ART was changed to zidovudine, lamivudine, and efavirenz in September 2019. Then in September 2021, as per the guidelines, the ART was changed to lopinavir, ritonavir, and dolutegravir as protease inhibitors were one of the best ART at that time. And later on, in April 2023, the lopinavir was changed to atazanavir in view of unavailability of the drug. He had 4 episodes of peritonitis and 1 episode of COVID pneumonia during this course. Initially, he was having severe wasting and severe stunting, and his height and weight were below 3rd centile. However, at the time of transplant, his height was 157.5 centimeters, which was minus 2.06 standard deviation. Weight was 40 kg, which was minus 1.9 standard deviation, and BMI was 16.7 kg, which is minus 1.23 standard deviation, and his sexual maturity rating was Tanner stage 4. The transplant workup was done in 2022 after he was registered for the cadaveric transplant. During the transplant workup, his UDS and MCU were found to be normal. The HBsAg anti-HCV viral markers were negative, and CMV and EBV IgG status was positive. He was called twice for the cadaveric transplant, once in April 2022 and another time in July 2022. However, both these times his CDC cross match was positive, hence the transplant was cancelled. Finally, we got a call again in April 2023 when the CDC cross match was negative, and he finally underwent transplant. At the time of the transplant, his CD4 counts were 1100. Viral load was not detectable. There was no evidence of any recent infections, with the PD fluid cells being nil and all the cultures being sterile. He was vaccinated against all the kill vaccines. We also did a PCR for other infections like herpes zoster, varicella, EBV, and CMV, and the PCR was negative. Stool for atypical organism was negative. Montus was positive, and interferon gamma release assay was negative. So kidney transplant was performed on 23rd of April in 2023. At that time, his native urine output was 800 to 900 ml. The donor was a 6-year-old boy who died in a road traffic accident with a blood group of A positive. CDC cross match was negative. For immunosuppression for the induction therapy, he received ATG at 3.75 mg per kg and methylprednisolone at 10 mg per kg. And for maintenance therapy, he received MMF, tacrolimus, and prednisolone. For prophylaxis, as the Montus was positive, he received isoniazid for 6 months and Valgan cyclophyll for 6 months, and this plan was to continue Septran for lifelong. Now I would like to invite my colleague from the Department of Surgery to enlighten us with the procedure during the transplant surgery.
Good afternoon, everyone. I am Dr. Sachin from Department of Surgery, Unit 4. I'll be talking about the deceased donor transplant. As ma'am explained about the recipient, I am going to talk about the surgical aspect. And donor kidney we retrieved from trauma center. It was a multi-organ retrieval. Both kidneys were harvested en bloc, and we chose right kidney. And on bench, we preserved this golden triangle which is between the ureter and the renal ileum, which preserves most of the blood supply to the upper ureter. Then we perfuse the kidney with 1 liter custodial organ preserving solution. Next. And the kidney was brought to the OT via donor box, organ retrieval donor box. On recipient, we gave a modified Gibson incision on the right side of the iliac fossa. We placed the right donor kidney in the iliac fossa, and then we started skeletonizing the external iliac artery and the external iliac vein, which was good. caliber. The donor renal vein with IVC cuff was anastomosed with an end-to-side fashion to the external iliac vein, and the donor renal artery was skeletonized with the Carrel's patch, aortic patch, to the external iliac artery in the similar fashion. And on declamping, the kidney was turgid pink, and there was a good urine output. And then we started to do this neo-ureterocystostomy was made, and the protocol renal biopsy was taken, and this is the kidney, this is the ureter which was well perfused, this is the anastomotic side, and this is the renal artery and the renal vein which have been anastomosed. And the perioperative period was uneventful, and the patient was discharged from our side with a good urine output of 4.2 liter, and the creatinine was 0.83. This is the post-transplant course. Ma'am will be taking over. Thank you.
Thank you. So post-transplant, he was continued on the ART, atazanavir, ritonavir and dolutegravir. Although the protease inhibitors are known to cause enzyme inhibition resulting in increased TAC levels, we chose to continue this ART, as changing of the ART in the peri-transplant period could have led to increased risk of reactivation. It was difficult initially to attain the adequate level of tacrolimus. Hence, after 2 weeks of transplant, ART was changed to tenofovir, lamivudine and dolutegravir. Post the change of ART, his tacrolimus levels crashed and he had his first episode of rejection 3 weeks post-transplant. The second episode of rejection was 6 months post-transplant, for which he was currently admitted. So post-transplant, he had 2 episodes of rejection. The first one was in May 2023 when he had antibody-mediated rejection. His creatinine level increased from 0.7 to 2.8. At that time, his TAC level was 3.2 to 4.6 nanogram per ml, which is on the lower side. And the biopsy was suggestive of antibody-mediated rejection. For the treatment, we increased the dose of tacrolimus to 6 mg per day to attain the adequate TAC level of 12.1. And following that, he received methylprednisolone pulses and 7 sessions of fixed plasma exchanges followed by IVIG and 1 dose of rituximab. The second rejection was in November 2023 when he had acute cellular rejection. His creatinine increased from a baseline of 1 to 1.5. At that time, again his TAC levels were low, 6.8, and biopsy was suggestive of acute cellular rejection. For the treatment, he received 3 doses of methylprednisolone pulse, following which his creatinine level has declined to 1.1. Post-transplant, he had episodes of infection. So in June 2023, he had urinary tract infection when he presented to us with fever and burning micturition. Urine microscopy revealed 60 to 80 WBCs per high power Phi, and the culture was sterile. His creatinine remained normal during this episode, which was 0.7 to 0.8, and he was treated with IV antibiotics. In September 2023, he had tinea corporis over the left lower limb, which was treated with terbinafine and topical voriconazole. In May 2023, his CD4 count dropped to less than 40, that was post antithymocyte globulin, for which he received azithromycin prophylaxis for Mycobacterium avium till the resolution of CD4 count. He also developed elevated transaminases and pancytopenia. The elevated transaminases were attributed to multiple drugs which are going on, which included tenofovir, lamivudine, MMF, valganciclovir, and isoniazid. Following this, MMF dose was reduced from 1000 mg per day to 750 mg per day, and valganciclovir and isoniazid were stopped 6 months post-transplant. Currently, the child has been admitted with us with acute cellular rejection. His hemoglobin is 11.3, creatinine has dropped to 1.1, which is the baseline. The electrolytes are normal. AST and ALT are 74 and 122, and current immunosuppression going on is tacrolimus at 3.5 mg per day, on which he is able to maintain the adequate TAC levels, MMF at 750 mg per day, and prednisolone at 50 milligrams per day. Now I would like to invite my colleague Dr. Rahul for the further discussion.
Before we go on to discussion, the histopathology slides are to be discussed. Sorry for the delay in between.
Sir, I'm really sorry, sir. This is the biopsy which we received in May 2023. And as here we can see that this is showing acute tubular injury here. And in the glomeruli, there was moderate glomerulitis. Interstitial fibrosis and tubular atrophy composed of 40% of the biopsied cortex. So the diagnosis which was given here was borderline or suspicious for T-cell mediated rejection. This was the second biopsy which we received recently only, and they showed 2 cores with nine glomeruli, none of which were globally sclerosed. And there is diffuse, we can see that the acute tubular injury is still here, persistent in this biopsy as well. Here we can see there is interstitial inflammation and acute tubular injury as well. And this area here is showing inflammatory cells in the PTCs as well. This is interstitial inflammation. And so here the diagnosis which was given was PTC was 2. The diagnosis which was given was acute T-cell mediated rejection 1B.
Thank you, Dr. Vandana. We'll move on to the discussion of the case. To summarize, he is a 17-year-old boy with a native kidney disease of posterior urethral wall with likely a transfusion transmitted HIV, dialysis vintage of 8.5 years, underwent deceased donor transplantation in April 2023 and had a turbulent post-transplantation course. When we look at transplantation in HIV, there are certain challenges and prerequisites that we need to worry about. Challenges predominantly in the terms of immunosuppression, the drug interactions, the differences, the difficulties that may arise during surgery, particularly the risk of infections, and the immunological issues that we had encountered in this child as well. Various governments of Spain, UK and USA have given criteria for prerequisite criteria for transplantation of HIV positive recipients. Of those opportunistic infections, some like PCP may be allowed in Spain but are not allowed in UK. That may have occurred previously. A CD4 count of at least 200 cells per microliter is desired, and a plasma HIV1 RNA load should be less than 50, that is undetectable on the routine evaluation. The second issue that we need to worry about is drug interactions. Ritonavir boosted protease inhibitors are among the most notorious, but these decrease the activity of enzymes CYP3, A4 as well as A5 by which tacrolimus and cyclosporin are metabolized. Also, we need to think about efavirenz and nevirapine that do increase the levels of these drugs. So it is a challenge to balance between the treatment by ART as well as the immunosuppression that you routinely require. The graph at bottom shows a child whose tacrolimus levels were very high at the onset, with tacrolimus dosing given almost daily or in a BD dose, and ultimately they had to shift to a weekly dose to decrease his TAC levels to the treatment range, which was similar to our child. Although we did not decrease to weekly levels, we had thought and discussed and ultimately changed the ART to tenofovir, lamivudine and dolutegravir. Our child had 2 positive complement dependent cytotoxicity cross match. I could not find any reports where CDC is positive, but there are certain reports of higher non-HLA autoantibodies in HIV positive recipients, and that may lead to a positive flow cross-match on transplant immunology evaluation. The false positive flow cross-match may be not found when the lymphocytes are not treated with pronase. There is also increased risk of rejection in HIV positive recipients. Generally, the incidence of rejection is about 10% in kidney transplant recipients. However, a large study showed that a biopsy-proven acute rejection in HIV positive individuals is about 38% at the end of 1 year and 2 years, going up to 41% of those having rejection at the end of 3 years. Also, because there are variations in the TAC levels due to ritonavir boosted PIs, it was found that ritonavir boosted PIs had higher incidence of rejection because of the intra-patient variability that we see. For induction immunosuppression in these patients, antithymocyte globulin is recommended for almost all patients and should be considered as high risk kidney transplantation. We do expect the CD4 count to drop after giving antithymocyte globulin. This, according to a paper published in NEJM, show that CD4 count dropped drastically after ATG induction, but normalized after at about 3 years of age. So with no long-term consequences as such. Also, although CD4 counts do decrease, we know that the incidence of rejection when we compare with lymphocyte depleting agents like ATG, their incidence of rejection is very low as compared to those without ATG. Also, in multiple case series up to prospective observational studies with 810 patients, it was found that ATG induction is better than any other induction or no induction in terms of rejection. We also need to give prophylaxis apart from the routine prophylaxis that we give in kidney transplant recipients. For PCP, we give routinely for all for 3 to 6 months. We may need to increase it to 12 months, or based on evidence, we may need to give it lifelong. Toxoplasmosis is covered again by cotrimoxazole. CMV prophylaxis is routinely given as for non-HIV positive patients. For candidiasis, some centers recommend fluconazole prophylaxis given once a week. We here follow clotrimazole mouthwash, as well as if available, mycostatin solution solo should be preferred. In our child, he had a CD4 count of less than 40, so he was needed to be started on azithromycin for Mycobacterium avium complex prophylaxis as well till his CD4 counts recovered. When we look at long-term trends in survival of kidney transplant in HIV positive, this has been increasing over the previous years, and in HIV positive recipients, if the HIV donor is HIV negative, there are lesser chances of rejection and more graft survival as compared to HIV positive donor as well. This is a meta-analysis that showed of around 1670 patients, covered the patient survival, graft survival and rejections as well as infection. So there was a 94% survival of patient survival at 3 years, 81% graft survival at 3 years, 33% at least one episode of rejection, almost 3 to 3.5 times that of general population, and 41% at least one infection that required antimicrobial treatment. This was a long-term data from South African cohort of around 51 patients, where they looked at both rejection as well as HIV-associated nephropathy, which is more common in their cohort. The graft survival was best when there was no rejection or HIV-associated nephropathy, and the least when HIV-associated nephropathy was seen in these patients. Transplantation is HIV in children is not much common. We do not see many case reports. These are case reports from two predominantly from UK, and this again from our series of 4 adult cases in Apollo hospitals at New Delhi. So kidney transplantation is feasible in HIV positive individuals, and drug interactions should be considered. Antimicrobial prophylaxis and vaccination prior to transplantation is important, and one should be very vigilant to detect rejection early. I would like to thank all the departments that were involved in management of this case. I will start from the kidney donor and his parents and departments of our institute. Thank you. Sir.
Thank you, Rahul. So we were very hesitant in taking this child for transplant because we had not done one in the past, and even our adult colleagues also haven't done HIV transplant. And we feared the two most important complications, and both of which happened in the same patient. But before I open this for discussion, we'll take comments from Dr. Rakesh first, who managed the ART of this child while before transplantation, and then finally a word about his ART by Dr. Sanjeev Sinha.
Thank you, Dr. So I think the case has been well presented, and the challenges were there mainly in terms of the drug interactions that we deal with. While on one side, the availability of fixed dose combinations have made treatments in general easier. Then, as we could see that, different drugs need different level of adjustment when you are with just the renal dysfunction, as well as, the enzyme reduction part. So that made the choice of drugs very difficult in terms of, getting the individual drugs and trying to titrate them. Some of the combinations that have been used finally are not standard treatment recommendations. But anyway, I guess the family was quite involved and they made sure that, the medications were given, and after start of the ART, the viral loads were suppressed. I think once you have the kidney function, then again you can be on the usual regimen of the tenofovir-based regimen. Again, has a component of nephrotoxicity. I think there would be ongoing challenges of HIV-associated nephropathy. I think as the long way to go, but I think overall a very challenging case. I think this part, and apart from that, I guess illnesses that the child was having as well. From the ART or HIV treatment perspective, definitely important challenges related to renal dysfunction to begin with, and subsequently interaction with the immunosuppressant.
Thanks, Rakesh.
Thank you. Thank you very much for the in the Department of Medicine, we started and since that time we have prepared OT and we have only 5,000 active adult patients who are being more than 10,000 registered in our. So that is from this patient came in 2018 to our clinic. And at that time, the CD4 count is for a particular like this patient around 800 CD4 count. So we have not started. But now, once guideline counted, like you just confirm the diagnosis or start then we started and from further we have changed the currently this patient is getting yearly as well. I'm not sure what the cause of second injection. He mentioned slide, but there is no side effect and we will continue this therapy. One more thing, tenofovir AF is more renal friendly. Tenofovir has some side effect. Thank you.
Dr. Sini, if you can make a comment.
Thank you for excellent. Thank you, Dr. Singh.
Thank you. First of all, happy congratulations to Dr. Bhagga, not here, Pankaj, and Aditi, and others. Division of Pediatrics at front. So I'm reiterating again, I've said it the success of kidney transplant, especially in children, depends on how well they are. And I feel privileged to say that no time I have got a child who is far age, all that time when we got, they are almost near normal children. As far as this patient goes, the surgical technique is same. You need to patient or the entire success is how the patient has been taken well care of by the department of pediatrics and medicine. Something I just have two things. One is, was any HIV testing done to again at the time of the previous what prompted us to do?
The surgery was done outside, that initial surgery of posturethral valve, and when he was taken in for treatment with us, then only it was tested. So even for hemodialysis outside, perhaps it was not tested or whatever. So we picked it up first. Comments from anybody else? Yes, Swami. Okay, if there are no other comments, then we'll stop here and we hand it over to the neurosurgeon colleagues. Thank you.
Respected teachers, colleagues, students, and dear friends. So, allow me to congratulate Department of Pediatrics first for such a excellent management of the patient, and continuing with the tale of immunosuppression versus reconstitution and so on, will present our own tale of striking behind the enemy lines when the target is surrounded all around by the enemy. So neurosurgery is known for precision and a targeted surgical strike, but here the target was surrounded all through the way by the enemy, and the stress hormone, that is the cortisol, was dysfunctional. So allow me to invite Dr. Shiv Krishna, who will present this case and take you through the tale of pituitary woes and fungal foes.
Good afternoon. Our patient is a 48-year-old lady from Bihar with complaint of progressive centripetal weight gain for the past 4 years, difficulty in getting up from squatting position for the past 2 years, easy skin bruisability for the past 2 years, worsening glycemic control for the past 2 years, bilateral lower lip swelling for the past 2 years, excessive hair growth over face for the past 1 year, labile mood with anger outbursts and anxiety for the past 1 year. The patient is a known case of type 2 diabetes mellitus and hypertension for the past 8 years on medication. This image depicts the features of Cushing's disease. The points highlighted in red are the features present in our patients. Our patient ticked the following boxes, important of which to note are hypertension, immune suppression, central obesity, proximal muscle weakness, and osteoporosis. On examination, the patient was hypertensive with BP of 132/94 on multiple antihypertensives. Features of hypercortisolism were present as shown in the image. Cutaneous features were nail hyperpigmentation and tinea corporis. Bilateral pitting edema was present. On the respiratory system examination, right side creps were positive. The CNS examination was completely unremarkable except for the proximal myopathy with power of 4/5. I would now like to call upon Dr. Preeti, a senior resident from the Department of Endocrinology, to take us through the endocrine workup.
So coming to the hormonal workup, we had a baseline workup of cortisol being 36 and an ACTH being 140. And we looked at the other anterior pituitary profile hormones as well. So we had a random growth hormone of 0.1, a reduced IGF-1 of 63. We looked at the TSH, which was also suppressed, for a free T4, which was just normal, and FSH-LH, which was below normal, which was coinciding with her lack of menstrual cycles. Estradiol was on the lower side, prolactin was on the lower side. Other issues were fever with sputum production. A CCT chest was suggestive of a thick-walled cavity with surrounding ground glass opacities, which was followed by a bowel examination, which was suggestive of cytology, which was Cryptococcus neoformans, which we progressed to a mucus plug examination on histopath, which was suggestive of a narrow-based budding, which was again suggestive of Cryptococcus. Serum cryptococcal antigen was positive for a titer of 1:256, and this patient was then started on antifungals, that is liposomal amphotericin B and flucytosine, and also a course of fluconazole was given initially.
Her CSF cryptococcal antigen was negative. After initial preparation on antifungals for 10 days, patient was posted for surgery. So first we look at why we diagnose the patient as Cushing's. A quick workup through the Cushing's algorithm. We first rule out any history of exogenous Cushing's, that is exogenous intake of glucocorticoids, and we look at the clinical likelihood of the patient having endogenous Cushing's. We then look whether the patient has discriminatory factors in the form of bruising, ecchymotic patches, striae, and osteoporosis. Since our patient already fulfilled these criteria, our patient had a high risk of being a likelihood of endogenous Cushing's. We then further worked up with late night salivary cortisol. We do not have a urinary free cortisol at our center, and followed by an overnight 1 milligram dexamethasone suppression tests. These tests were abnormal. They were repeated twice. And now we further went into the workup of Cushing's disease. So this was her 8 a.m. cortisol, which was 30.72, 11 p.m. serum cortisol of 33, a late night salivary cortisol, our limit being 0.5, therefore it was clearly elevated. Our ONDST has a limit of 1.8 and therefore it was clearly high. Similarly, LDDST also has a normal range of 1.8. This was clearly elevated. We followed it up with a high dose dexamethasone suppression test. Pre-test value was 36, post-test was 33, which was indicative of only 7% suppression. In view of our ACTH value being elevated, we went on to diagnose this patient as an ACTH-dependent Cushing's syndrome. We followed it up with a pituitary MRI. We did see an adenoma, however, the lesion was cellular and also extending into the sphenoid. Therefore, when the view of an ectopic Cushing's disease was kept into mind, this was also because the HDDST was not adequately suppressed. We went forward with an IPSS, that is an inferior petrosal sampling, and then we established whether a pituitary gradient is present or not. So this is our IPSS setup, where we look at the ACTH levels in the inferior petrosal sinus on the right and the left, and we compare it with the peripheral vein. If you look at the right side, the values of 260, 240 and 208 and similar values in the peripheral vein, which suggest that the right side was not cannulated correctly. But when we look at the left side, we find that the ACTH gradient of 4,500, 3,900 and 4,700, which give us a ratio of 19, 19.5 and 20.9, which suggests there is a central gradient. We followed it up with an IJV peripheral sampling. Here again, we found that a central is to peripheral, that is ACTH gradient was found, that is a right to periphery of 1.07 and a left to periphery of 1.9. This suggested that our impression was that the site was localized to the sella or to the sphenoid region. So our final impression on basis of anatomical localization was that there is a central gradient with a central gradient on the IPSS and IJV sampling, with an MRI suggestive of a sella sphenoid lesion. There was no ectopic site that was localized on the Dotanov or the CT scan, and HDDST, which was less than 50% suppressed. So, is this a lesion which is ectopic, ACTH producing pituitary adenoma? The following was the pre-op medical management. In view of refractory hypokalemia, neuropsychiatric disturbances and dysglycemia, patient was initiated on ketoconazole. However, in view of the cryptococcal infection, patient was later started, as discussed, on liposomal amphotericin B and flucytosine. Patient was posted for surgery after 10 days of ongoing therapy, and we gave IV hydrocortisone on the day of surgery and also in the immediate post-op period to prevent immune reconstitution inflammatory syndrome. I would like to invite my colleagues for further workup.
Good afternoon. So this was the MRI imaging. This is plain T1. Here we are seeing that there is some lesion within the sphenoid sinus which is continuous with the sella. And even in this T1 sagittal images, we are seeing that the posterior pituitary bright spot is maintained. And there is no large lesion. Like in this T2 image, we are seeing that the sphenoid sinus lesion is continuous with the sella, and also there is some T2 hyperintense mucosal inflammation around it. And this is post contrast. Here we are in this sagittal, and there is another coronal image also, which I will show you. In the base of sella, there is a hypo enhancing region, which is on like the sphenoid sinus lesion is also enhancing on the same intensity as this lesion in the base of the sella. This is the plain T1. And in these coronal images, we can see that the sphenoid lesion is the lesion in the sphenoid sinus is mildly enhancing with along with the lesion in the base of the sella, and it is T2 hypointense, completely T2 hypointense. So this is an image of CECT that was done here, and here also we can see that there is enhancing lesion within the left sphenoid sinus, which is contiguous with the base of sella and with a cellular lesion. In this sagittal images, we are able to appreciate that there is a defect within the floor of sella and the continuous lesion within the sella and the sphenoid sinus. Here also we can see that there is erosion of the base of sella. So coming on to the chest X-ray, we have seen that there is a cavitated lesion within the right upper lobe, which was confirmed on CT. So initially we were little suspicious about any lesion within the pituitary, but on these coronal images we noticed that there was a hypoenhancing area on the left side of the sella, and also because of this T2 hypointense lesion in the sphenoid sinus, we were a little confused if it was a fungal lesion or if it was the pituitary lesion that was extending. But yeah, so our diagnosis was fungal infection in the sphenoid sinus and with query pituitary microadenoma on the left side of sella.
So we can see that the patient had a very high risk of any surgical procedure for that matter because of uncontrolled hypertension, fungal infections of lungs, a poor general condition, suspected infection in the sphenoid sinus, which was probably cryptococcus or so till now with the given information. And if we operate this patient, there might be a chance of intracranial seeding of cryptococcus infection leading to meningitis and encephalitis. So this patient had a very high intra and perioperative mortality risk, and due to poor condition, the anesthesiologist advised initially for optimization. However, because of ongoing over hormone production, this patient could not be optimized and surgery was the only solution. So we took the patient for surgery under death on table risk, and the goal was quick in and quick out because the patient cannot survive a long enough procedure. So Dr. Kushagra Pandey will take you through the rest of the tale.
So the patient was counseled regarding the risk associated with surgery due to the aforementioned issues, and she was ultimately planned for excision of the lesion. So historically, the microscopic approach has been used to remove the cellular lesions, but with the advent of endoscopes and the panoramic view which they offer, nowadays the gold standards are becoming the endoscope. But everything has its own cliche. So endoscope requires patience and microscopic approach is swift. So in this, in our patient, we didn't want to submit her to unnecessary surgical stress for too long. So we finally decided for a hybrid approach in which we first approached the patient for the resection of the lesion via microscopic route, and then finally we did a check endoscopy in the end too. So now I'll present the operative video for the patient. So right uninostril transseptal approach was taken, as can be seen here, and incision was given at the osteocartilaginous boundary of the nasal septum. The bony septum was removed and the heel of vomer was removed. So here we can see we are taking biopsy of a brownish colored lesion from the sphenoid mucosa, which we sent for the frozen section analysis. After this, the sphenoid septum was removed to reach till the sphenoidal lesion. We can see a yellowish lesion here, and this is the yellowish brown tissue which we found at the sphenoid sinus. We resected it completely as much as possible. So continuing with the surgery, we found that at the left side the cellular floor was deficient, and we can visualize a yellowish tissue which is popping out through it. So we directly reached the pituitary microadenoma tissue. We can see here. So the microadenoma which was there was resected. This is the yellowish cellular tumor tissue which was found at the deficient left cellular floor. It was resected completely. So after this, as I described in the hybrid approach, we followed this up with a check endoscopy. We used 0 and 45 degrees endoscope to look at each and every crevice of the nasal cavity So here we can see the sphenoidal mucosa and the sinus, and the no residual brownish tumor tissue which was earlier seen is now seen here. After visualizing this, we even took our endoscope to the deficient cellular floor, and we can see the glistening pulsating arachnoid membrane, no breaches there, and no residual tumor tissue can be seen here. So this is the post-resection check endoscopy photo. So after this, the hemostasis was achieved, and the fat which was harvested from the patient, it was packed into the nasal cavity. So the main intraoperative findings were, we found a brownish gray colored soft mildly vascular lesion in the sphenoid sinus, and the frozen section was aspergillus infection. The cellular floor was deficient on the left side as shown, with the tumor protrusion was present. The gross total excision was done and cellular floor packing was achieved. So this was the post-operative non-contrast CT scan of the head. We can see post-sphenoidal surgery operative changes here. The fungal tumor tissue which was occupying the sphenoid sinus has been removed, and the cellular operative cavity also looks good. There are no signs, there is no evidence of any pneumocephalus or any intra-op cavity hematoma which is seen here. Now I invite my colleague from neuropathology to discuss the histopathological aspects of the condition.
So these are the histopathology images of the specimen that was sent. First, I'm showing the cellular tumor. The upper part is showing the normal pituitary, and here on lower part we can see the tumor, which is composed of sheets of cells which appear monomorphic, similar in appearance, with presence of moderate amount of cytoplasm, round nuclei with stipple chromatin, and occasional mitosis. These are the stains for hormones and cytokeratin on the tumor. Pancytokeratin is diffusely positive, and it is diffusely positive for ACTH hormone, and it is negative for all the other pituitary hormones such as growth hormone, prolactin, LH and FSH, TSH, and the MIB is around 2 to 3%. These are the stains for the transcription factors involved in pituitary tumorigenesis. The tumor is diffusely positive for TPIT, which is responsible for corticotropic differentiation, and is negative for PIT1, SF1, and GATA3. This is the tissue that was sent for frozen as sinus brownish discolored tissue. Here on the upper part, we can see the sinus mucosa with presence of dense inflammatory cell infiltrate, composed mainly of plasma cells and lymphocytes. On the lower part, this constitutes a fungal ball with presence of numerous fungal hyphae intertwined in between. Here we can see an additional pigmented brownish structure, which I will describe further. So this is a higher part image of the fungus. We can see the presence of septate fungal hyphae. These are the septations. They are slender, parallel walled, and with presence of acute angle branching. So morphologically, this constitutes fits well with aspergillus. Here we can see the presence of a pigmented fruiting body, which is the reproductive structure of an aspergillus. These are the conidiophores, and this is the metallae and phyalites radiating from the center. So the diagnosis on the pituitary was densely granulated corticotroph pituitary adenoma with presence of aspergillosis in the sphenoid sinus. These are the histopath images of the lung biopsy which was sent earlier, and here we can see this was a bronchial lung biopsy sent as a mucus plug in the right upper lobe, and here we can see the presence of acute inflammatory exudate composed mainly of polymorphs, lots of fibrin. And then there are some negative shadows and refractile circular structures on low part. This is the higher power image of the same. We can see circular refractile structures with presence of a refractile negative shadow around it. Here we can see presence of narrow based budding. These are the special stains, special histochemical stains performed for demonstration of fungus. And we can see thin fungal wall stained with pass with diastase resistance. And this is the silver methenamine stain, which is again highlighting the fungal wall. So this fungus, which is variably sized, mainly composed of yeast forms, which are around 3.5 to 8 micron in size, with presence of narrow-based budding and thin walls, morphologically corresponds to Cryptococcus. So the lung had cryptococcal infection, while the histopath of the pituitary tumor was a densely granulated corticotroph adenoma with concomitant aspergillosis of the sphenoid sinus. I'll now call upon Dr. Akshay to discuss further.
Thank you. Good afternoon, everyone. Post-operatively, the patient was started on systemic antifungals in view of invasive aspergillosis as well as cryptococcosis. There was tapering of the cortisol hormonal support, which was hydrocortisone. She was started on oral replacement. In view of posaconazole and prednisolone therapy, post-operatively, the cortisol and ACTH levels were not monitored in this case. And after completing 4 weeks of antifungals, she was switched on to oral voriconazole, which was given long term. Posaconazole was stopped and she was tapered to a replacement level of prednisone. Post-operatively, she experienced improvement in the proximal myopathy. She was ambulatory with support. There was reduction in the features of hypercortisolism, especially the cutaneous ones. There was improvement in glycemic control, and the antihypertensives were tapered to a single drug, amlodipine 5 mg. There were no further neuropsychiatric outbursts reported. Coming on to the discussion. Literature is very sparse with juxtacellular fungal infections in a patient with a pre-existing Cushing adenoma or a pituitary adenoma. We found a single case where fungal hypophysitis was reported in a patient with a corticotroph adenoma. In their patient, they went for an endoscopic excision of the lesion, and the histopathology helped to diagnose fungal hypophysitis in a pre-existing Cushing or corticotroph adenoma. Systemic antifungals were not started in this case because it was limited to the hypophysis. We didn't find any other cases, but coming on to a more interesting discussion of mimics, where fungal juxtacellular or paracellular lesions have mimicked to be pituitary adenomas and have been treated and operated as such. 2 cases have been reported from our department as well. These cases represent a radiological diagnostic dilemma, and surgery is a must for getting histopathological diagnosis in such cases. And different authors have different views on the need for systemic antifungals. In our case, we started systemic antifungals because there were 2 different fungal infections in 2 different locations. As concluding remarks, surgery is possible even in such high-risk patients if a clear-cut surgical plan is taken. As in our case, we went for a hybrid approach, a swift microscopic approach with a panoramic endoscopic and all. And multidisciplinary approach is key for the good optimum outcome we saw in our case. I'll call upon sir for the concluding remarks.
Thank you, Akshay. And you have a next slide also. How do you move that? Oh. I think the presentation shown by the pediatric department just showed that how important it is to have a multidisciplinary approach. And I believe that CCR should be presented with such kind of patients where so many departments are involved. I believe the old saying is that I bandaged the wound and God healed the wound. But I believe between I and God comes the role of many departments. And here, for example, here the endocrinology department basically is the department who manages the 90% part of the patient. We just manage maybe the 5 or 10% part of the patient. And I must congratulate them and their hard work, because of which we were able to operate. Because on the day of surgery also, the anesthetists refused to take the patient. And I asked them to call directly the Department of Endocrinology, because they said so probably this slide was missed by me, and that's why it's not there. I was not aware that he has added this slide later on. So, but I believe that even their role was very important, because they ultimately agreed to induce the patient as an emergency case, and we decided to operate this patient. If there are any questions, I will be happy to answer them. And I would also request Dr. Khadgawat, if anybody has questions for him, then maybe you can ask them.
This was not very difficult case to diagnose for hypercortisolism. Most difficult part was very severe amount of hypercortisolism. At one point of time, we thought of bilateral adrenalectomy also, so patient survives and get a second chance to come for surgery. But neurosurgeon were ready for surgery, so we opted for that. A lot of discussion with neuroanesthetist,
they were not ready yet. Blood glucose was not controlled adequately, but it's very difficult to control blood glucose adequately in these patients who have severe hypercortisolism. Both unsuppressed as well as suppressed cortisol levels were more than 40 microgram per dl. We do not know what was their exact level, but more than 40 is severe kind of hypercortisolism, and if we delay for few days, they are very much likely that we may lose these patients. So we decided, requested neurosurgery team to go ahead. We cannot do more than that. We cannot control that. And finally, we ended and patient has gone home. Still, we are not sure that whether we have achieved remission from hypercortisolism or not, because that we assess after 3 months time from the date of surgery. But there are clear clinical improvements suggesting that we may have patient may go into remission.
How often do you see fungal infection?
I think chest fungal infection we have seen previously, but pituitary fungal infection I am seeing for the first time.
Rajesh, in this high dose infection case, there is not significant fall of if I got it right that high dose dexamethasone suppression, the cortisol level didn't fall.
Only 7% suppression was there.
So,
what do you expect higher fall?
Yeah, so basic purpose of doing high dose dex suppression is to differentiate between central versus peripheral origin of ACTH, because there might be ectopic ACTH production from some peripheral tissues. 80 to 90% of these pituitary tumors, they suppress well on high dose dexamethasone suppression. If we see more than 90% suppression, we say that it's likely to be a central origin. But 10 to 15% of central tumors also do not suppress to high dose dexamethasone, especially if there is a very high cortisol productions. In that case, they do not suppress. So it's a good test, but to differentiate between central versus peripheral, but it's not a very robust test where we see more than 100%. Because of availability of FDG PET and other modalities nowadays, it's almost obsolete test to do.
Or promoted you to go for sampling inferior petrosal solids? Great. Why did you go for the inferior?
We did. Yes, so that's our departmental protocol, because previously we have seen that even there is small adenoma is visible, it's better to do IPSS. Previously we were doing internal jugular vein sampling to demonstrate there is increased ACTH versus peripheral. So in these patients nowadays we are doing, and more so reason is doing in all patients is because we are continuing with 2-3 theses on IPSS versus peripheral, so we are doing in all patients.
Thank you, sir. If you have any more questions?
This patient is having some streptococcus. Suppose if there is no streptococcus and this infection, would you think the colonization or the paranasal sinus? Should we need to take treatment? In the literature, we have shown that pituitary adenoma with the fungal infection, they have not given any.
Sir, I think this patient required systemic treatment because any which ways there was.
We have lung infection.
And one of the relative.
Fungus is not invasive. It is the paranasal sinus. It is a colonization.
But I mean, this is one of the relative contraindications for transnasal surgery is infection in the sinus. But even then, we did the surgery through the transnasal route because me, Joseph, and Deva, we had discussed that it appeared to be more like a tumor there rather than fungal infection there. But though, I mean, the radiology was kind of atypical as there was enhancement in the peripheral part.
You have violated all the anatomical
boundaries. So now we have violated all the anatomical boundaries in a patient, and with CSF. Because once you have fungus inside brain, I mean, the patient is gone. So it's better to be on a conservative side.
We have already started antifungal before surgery.
Yeah.
This was based on ENT consultation and their opinion, and that initial
QH preparation was just to be started because this is a highly immunocompromised condition. Severe hypertension.
And they also, I think, they were more accidentally detected from the hypophysitis. It was not diagnosed prior to their surgery.
Yeah.
Yes.
So majority of patients are mimics.
No.
They are not previously diagnosed.
In that case, I think it was diagnosed after surgery.
I think in one case we have seen this pituitary adenoma with the kaleidoscope.
Dr. Suri has operated maybe more than anybody else, I think, if he wants to add something.
We just put the microscopes and endoscopes. Give a good the only surviving factor. We try to evaluate the division that. But our surgicals use added and good over the years. Close to, I would say, 90% revision.
Thank you.